Hello, I'm Mohammed Bashir for the CTSNet Aortic Portal. Thank you very much for joining me today. We are at the EACTS 2015 in Amsterdam. It's a lovely city, and for this we lined up a very nice topic with a very eminent panelist today. On my left here, I've got Dr. Joe Caselli from the Texas Heart Institute, Baylor College of Medicine. And I've also privileged to also have today Dr. Toraf Sund from Massachusetts General Hospital in Boston, and also Dr. Yutaka Okita from Kobe University in Japan, and also Dr. Michael Borger from Columbia University Medical Center in New York. The topic we planned for you today is about strategies, tips, and pitfall for management of porcelain aorta. We're all faced with this grave situation where we need a strategy and we need also some tricks under our sleeves to deal with it. And for this reason, I'm going to be rounding a few questions with my panelists today who will also elaborate further on this. My first question, we probably start with any of you. It's about what, if you're faced with this situation, what is your individual strategy? What individualized strategy hinges that ought to be employed in case of an anticipated severe circumferential aortic calcification? Tor, you want to take this one?
Well, of course, the first issue is what operation did the patient come for. So if it's coronary revascularization, then the easiest thing to do is to do their operation off pump. And I do a lot of my coronaries with composite T-grafts. So you can certainly do an aortic no-touch technique with a T-graft if it's coronary revascularization. If it's mitral valve operations, well, you can do a lot of mitral valve operations just with fibrillation, so cool enough to assure fibrillation, so cool to 28 degrees or something like that, and assure yourself that the heart will continue to fibrillate. And you can do a mitral valve repair or even replacement that way. The hardest problem is if you've got to replace the aortic valve, of course.
Yeah.
And sort of the traditional approach, I suppose, is to use circulatory arrest and cool down, arrest, do your distal anastomosis, then clamp the graft, and do your aortic valve operation as you're rewarming.
Right. Okay. Dr. Caselli, any comments on this?
Yeah, you mentioned the word unanticipated.
Yeah.
I think today, in today's world, for severe porcelain aorta, the calcification level, generally you'll pick it up on plain x-ray, you'll pick it up on a heart cath, and then I think if you're suspicious of that, you follow up with a CT scan. I think intraoperatively, you may need to, in addition, have an epiaortic ultrasound evaluation. I think the key is that in the native form, it comes, and I think as Thor kind of alluded to, it comes in spectrums. A porcelain aorta can literally be what we refer, as a lead pipe, where it's a circumferential heavy calcification, and it's just from the aortic valve annulus up into the arch, or it can be in the form of some medial calcification, which is prominent in one area of the aorta and not so prominent in the other. And I think you can tailor your operation somewhat based on the severity of the calcification.
Right. Michael, Dr. Caselli mentioned something about screening patients preoperatively. Should we just get everybody into the multi-slice computed tomography to just clear out that the aorta is actually good to go before, for instance, embarking on aortic valve, when we do a sternotomy and then we found, oh my gosh, this aorta is so calcified? What's your take on this?
I don't think a CT scan is necessary. I agree with Joe. Usually you've got the hint already from definitely from the cardiac catheterization, from the echo as well. If you see that echogenicity in the ascending aorta, that should also tip you off. And then other things that just make you have that in the back of your mind are the usual risk factors. So patients that have had mediastinal radiation, especially those more than 10 years ago, those patients with familial hypercholesterolemia, which is very, very aggressive hypercholesterolemia, not the usual ones that we're dealing with, or the patient that have had a previous homograft, of course. If you have any one of those situations, I would definitely get a CT scan before, but to routinely apply it to every single aortic valve patient, I think it would be a pretty low yield and probably not necessary.
Right. Yutaka, what's your take on this?
I think I think we should take all CT scan in all patients because we have a very elderly population and
That's
very
true.
chance
That's
to have a calcified aorta. And the worst case is only calcification is easy to handle, but the worst case is shaggy aorta, very atherosclerotic and 5 millimeter thick. You never know by CT scan is such a thick atherosclerosis unless you order the enhanced CT. So we routinely use the epiaortic scan after open the chest and the echo directly. We found some thickness of this thickness of atheroma in the aorta. It is a bad thing.
Right.
And do you then axillary cannulate if you see that? Does that trigger you to do axillary cannulation? Or
That's a
what's your next step?
question. The normal is the ascending aorta, the fluoroatheroma. We never cannulate. We cannulate the multiple cannulation. We use the femoral and axial, or maybe apex left ventricular apex cannulations.
Right. Michael?
For the porcelain aorta, not the shaggy aorta that's full of soft atheroma, for the porcelain aorta, the brachiocephalic artery is usually spared. And so I've used that for a proximal vein graft if I really don't feel comfortable about doing some sort of extensive Y graft, total arterial. Or I've also used it in a case where I didn't want to do it op-cab, and so I've cannulated the brachiocephalic artery just to go on pump, just so that it's easier for you to do your anastomosis while still avoiding that proximal anastomosis.
Right.
Our routine cannulation for that situation, and I agree, the brachiocephalics, except in some rare situations, arteritises and things, is pretty free. And we would just sew an 8 millimeter graft on the distal innominate artery and just keep all your options open. It's out of the way, and it's just another way to go about it.
Right. Tor, you said something about like opening up and then facing this unanticipated situation. You would go on, you would use deep hypothermic circulatory arrest. Could you elaborate more on that approach?
Well, I think it's one of the options, but I'll, as did Joe, I'm going to fixate on this issue of it being unanticipated. In this day and age, it should be vanishingly rare that you're surprised. And we'll see, as everyone else in this group, patients referred in from another hospital, and it just breaks your heart when someone's gone in there and opened up, they've done a sternotomy, and then discover that the aorta is calcified and they back out.
Yeah.
And sometimes the patient's still intubated. Sometimes it'll be a week between the time that they've done the sternotomy and they get referred in. That just shouldn't happen very often in this day and age. It's hard to imagine. I'm sure it can, but it should be very uncommon that someone gets through all of those usual tests. They get through a cath, and no one saw calcium on the aorta in the cath. They have an echo, and no one saw calcium on the aorta. That's the biggest piece of advice, I think, is you've got to develop a strategy before you get in the operating room.
Right.
But circulatory arrest, to get back to your question, circulatory arrest is certainly a way to manage it. The trouble is, if the whole arch is calcified, then you can pretty much buy yourself an arch replacement, and it's a little bit, you kind of can't stop. You can't find a place to stop because you've got to have something to sew to distally. But circulatory arrest is a good way to manage it.
I've picked up on the point that you said, some people, they might back off from proceeding, even with a circulatory arrest. Michael, can we identify which patients are likely to do well with an open AVR or surgical aortic valve replacement, and which patients actually are not in this case, or we should refer them for
preoperatively, you mean?
Yeah.
I would still say for the young patient, I would still go ahead and do the conventional operation, obviously explaining to them that this is going to be a higher risk situation than normally. I don't think in a really young patient you should be turning to TAVR as the solution, because you're just pushing the problem off on the next surgeon down the road 5 years from now or 7 years from now when that TAVR fails. So if the patient is below the age of, say, 50, I'll definitely recommend a conventional operation. If they're over 70, I would say TAVR for sure. In between the two, it's going to take a careful discussion with the patient.
That's great. Dr. Kiselli, you're faced with this situation. You're thinking of deep hypothermic circulatory arrest. Would you clamp or not clamp the calcified aorta, during a routine aortic valve replacement? And if you do clamp, what tips or what pitfalls you be thinking of? This is very important for the viewers.
Well, if the calcification's all down and around the root, which it is on occasion, and it diminishes as it goes up towards the arch, in some of these patients with a large soft clamp, you can. But if you have any question in your mind that it really doesn't involve the area at the base of the innominate artery, then we would carry things out with circulatory arrest. And one of the utilities of having a graft on the distal innominate artery or even up on the carotid artery is that you can continue to perfuse the left side of the brain with an antegrade technique by placing your anastomosis or your cannulation far enough distal that you've got some pliable artery proximal to that you can occlude, and then allow the right carotid artery to be perfused.
That's great. Michael, I'm going to go back to you. You mentioned something about TAVR and TAVI and SAVR. And there's a big controversy around this in this situation. Would it be possible to draw a line between the utility and futility between TAVR and a surgical AVR in this situation?
Well, if it's definitely an older patient, I would be very hesitant. If they're over 70 or 80 years old, I'd be very hesitant to offer a conventional operation, because even if you do some heroic measures, the risk is definitely increased. You've got a longer cross-clamp time, you've got a longer cardiopulmonary bypass time. Whereas with TAVR, it's actually pretty straightforward in the porcelain aorta. It's not nearly as problematic for the TAVR operator as it is for us as surgeons, and therefore I don't think that in and of itself is enough to say, oh, this is a futile procedure. If they got other problems, okay, but if it's just the porcelain aorta, it's technically a pretty fairly straightforward procedure for the TAVR people.
All right. Tor, do you have any comments on this?
Yeah,
I mean, we're trying to establish, I know that the guidelines are out there on the usage of TAVR, but in such situation, what most people would do is close the aorta and refer the patient for a TAVR or a TAVI procedure, because they seem to think that this patient is not suitable for, any conventional method. What's your comment on this?
I think it's like everything, it's a case by case. On one end of the spectrum is the patient with a terribly calcified root, the whole root, the whole ascending aorta is porcelain. That, from a technical standpoint, is going to be extraordinarily difficult to deal with. From a technical standpoint, the coronary buttons disappear because they're calcified, and it's a mess. Yeah. Now that's usually somebody who's quite elderly, so everything favors TAVR in that situation. The other scenario, sort of on the other end of the spectrum, and I've heard Michael talk about this, is the setting of the calcified homograft, which is talk about the definition of a porcelain aorta. That's really the definition of a porcelain aorta. The CT scan on that can be quite dramatic, and we've all dealt with that situation. I think it's worth making one specific comment about that specific situation, is that when you've got a porcelain aorta secondary to a calcified homograft, that calcium, Magdi Yacoub used to say, the calcium's not invasive. So you're able to open the homograft and decalcify the root very carefully. Don't tear the coronary buttons and such. But the calcium will be confined to the homograft itself, and at the end of the homograft, at the edges of those buttons, the calcium will be gone. So they won't have truly calcified buttons if you're careful around the buttons. It's almost like an endarterectomy of the calcium from the homograft. Sometimes in the setting of a calcified homograft, you need to look at other options, and Michael's talked about some of the exciting options related to sutureless valves, which
It's
I'd be
a good
be interested in
patient
hearing.
population for a sutureless valve because you know, getting on cardiopulmonary bypass is not the problem with these people.
Yeah.
It's getting rid of that calcium, but you don't need to. You just make a transverse aortotomy just above the homograft, cut out the leaflets, and then drop in the sutureless valve. But one point I wanted to make, though, also is that, you know, we're all busy aortic surgeons, and our definition of porcelain aorta is probably not what other people's definition is. And you see, when you're talking about futility, you actually see sort of the opposite problem, the creep
That's true.
that all people are now being labeled as having a porcelain aorta. You know, working in a center at Columbia where we do a lot of TAVR procedures, and I see some of these patients that are sent in because of a porcelain aorta, and I look at the CT scan, and I'm like, that's not a porcelain aorta, that's just some calcium in the aorta, and that's not that difficult of a problem to deal with.
Right.
It's a diagnosis that it's an epidemic now, now in the age of TAVR.
Right. So what's the panel agreement then on what is porcelain aorta, so that we can view this to our viewers. So what is then a porcelain aorta, so that, you know, we clear out the confusion by people thinking that this is a porcelain aorta, as you mentioned, Michael, that, you know, in your situation, in your you know, you're thinking that this is not. So is it a circumferential severe calcification of the whole aorta, or is it a certain part of it?
I think Joe said it perfectly. If it's circumferential, it doesn't matter where it is, it's going to cause you problems.
Right.
Either your aortotomy, cross clamp, or even just putting the valve down across that ring of calcium, it makes it very difficult. Whereas it's non-circumferential, you can make your aortotomy sort of a little bit, you know, a hockey stick, or even completely vertical.
Right.
There's other ways to get around it. So I would say if it's completely circumferential, that's what I would call porcelain
Great.
aorta.
Joe, any comment?
Most of the time, and I use the word the native porcelain aorta as opposed to the non-native, which would be homografts and tissue roots. And most of the time, in those cases, the aorta distally is not so involved in the calcification, and it can be used as a site for a distal anastomosis if you have to replace the aorta in that setting, or it is usable for cannulation in cross clamping. In the areas where we see a more diffuse porcelain aorta that involves the arch, et cetera, is in the irradiation patients and in the post aortitis patients.
Right.
A lot of patients that have these porcelain aortas, they probably had an unrecognized aortitis for one reason or another, you know, in the distant past, and then the healing process of that is the laying down of calcium. And the important difference is that it's not it's not an intimal calcification that you see in an atherosclerotic pack that we're so used to dealing with in others. This is actually a medial problem, and it's one of the reasons that cleaning that out and carrying out an anastomosis in the form of an aortic replacement can be so precarious.
Great. I'm going to go back to you, Michael. You've touched base on the TAVR and your experience with that. What's the most suitable delivery approach for a TAVR in this situation, in the porcelain aorta?
I think we're getting further and further into transfemoral,
Right.
and it works well. I would definitely say transfemoral first.
Right. Yutaka, do you agree with the transfemoral approach, knowing that, you know, a porcelain aorta indicates most of the time that actually the femorals are also heavily calcified? Would you go for a transfemoral approach?
We Japanese have a problem with a small 80 years old ladies, 40 kilograms. The usual access is very small, so, and usually they have a calcification deep into the roots, so, and the narrow VA junction. So we exclude from the TTA we are such a patient. We do ordinary surgery, or sometimes bent-over operation with such ladies. So. But it depends on the technology. So
Yeah.
right.
Yeah. Just I'm going to touch the last question here about the partner trial, and I'm going to send this question to you, Tar. The partner trial identify predictors for neurologic sequels from surgical aortic valve replacement or TAVR. Would you like to comment? Are you in agreement with the predictors that the partner trial, or would you like to add any comments or any suggestions on this further?
Well, I suppose the trouble is it's a moving, it's always a moving target. So the neurologic events, I mean, it's hard to imagine, but it's the facts. Neurologic events with the current generation transcatheter valves are extraordinarily rare. I mean, we wouldn't have thought, first of all, we didn't think TAVR would work. And then second, it horrifies us to think about wires and cannulas going through these arches, but amazingly enough, it works pretty darn well. So
As
yeah, it's
enthusiastic as we are about TAVR, and the 14 French, I agree, has made a lot of patients accessible from a transfemoral standpoint, no doubt about it, that we'd had to do before. In the partner trial, you're really looking at clinical stroke and neurologic
absolutely
sequela. It's still a lot of information needs to be gathered on the subclinical, you know, and people even talk about the long-term consequences of early dementia, you know, from some of this subclinical business that goes up into the head as we traverse it with the wires and devices that we use.
Unfortunately, if you do diffusion-weighted MRI after a routine aortic valve replacement, there's a lot of stuff up in the head too. So
Yes, that's true.
we're
Michael,
opening Pandora's box there a little bit.
any comments on the partner trial and the neurologic sequel?
Yeah, the stroke rates for the S3, so SAPIEN 3 intermediate group were lower, and for the high-risk group also lower than partner. I think they are getting better. They are, of course, developing these filters, but I'm not sure how much those cerebroembolic filters will be, what kind of effect they can prove if the rate keeps dropping and dropping. But I agree with Joe, though. It's the subclinical insults have a particular importance as we move into lower risk patients and younger patients. So a 9-year-old with a few cerebral emboli might not have the same clinical implications as a 40-year-old, or definitely doesn't have the same clinical implications. And therefore, as we get into these lower risk patients, this is something that we'll have to look at very critically.
Right.
In the younger, lower risk patient, you would imagine, though, that the intimal atherosclerotic load that would be potential for cerebral embolization would also be lower, and so hopefully that similarly the stroke rate would decrease commensurately.
Mm-hmm.
All right, look, I'm sure you've had all a long day. I'm really honored to have this discussion with you today. I thank you very much for your time and your participation. From the CTS Net Aortic Bolter, this is Mohammed Bashir. Thanks for joining us. Bye-bye.
Thank you.